Dr. Cohen, may we proceed to the public comment session?
Yes, that would be great.
Thank you very much. So at the onset of this session, I'd like to welcome and thank the public speakers for addressing the committee today. We take very seriously what you tell us and look forward to your presentations. To all speakers today, I want to mention that we have a limited time for a public comment. And in order to make it through all the speakers, it is extremely important that each of the speakers limits his or her remarks to the 3 minutes allotted to them. We will be displaying the time on a timer that will cycle through various colors and then inform you of when your time is up. All speakers today have submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. Again, to the commenters, I want to say that as you reach the end of your allotted time, I will thank you with the following phrase. Thank you for your comment. Your time has expired. If you extend 15 seconds past that time, I will say the following. As a courtesy to other speakers, we ask that you conclude your comment. And if you extend to 30 seconds past your allotted time, I will ask that your microphone be cut and state your comment time has expired. Thank you very much. So again, thank you for the public commenters, and we'll begin with our first commenter, Mr. Del Bigtree. Please come to the microphone. Please state your name and any affiliations that you have. Mr. Bigtree.
Dr. Romero, I'm not sure he's on yet. Would you like to skip him and go to the second person?
Thank you, Stephanie. Yes, so next we'll go on to Dr. Richard Younghans, and excuse me if I mispronounced your name.
You got
Dr.
it.
Younghans.
Yeah, my name is Dr. Richard Younghans. I'm an immunotherapist, hematologist, oncologist, trained with Thomas Waldman at the NCI, and I'm associate professor at Boston University School of Medicine and president of IT Bio LLC, an immunotherapy company in Cambridge, startup, I should say. I have a technical comment about the antiplatelet antibodies. If I have time at the end, I'll allude to, but I want to jump into what I consider the elephant in the room. That is prior infectees, people who've been infected previously. I contend have a superior immunity to any conferred by these very good vaccines even. And if I'm right, then we're subjecting patients to risk unnecessarily, however small these risks are, which are being addressed today. It also wastes a drug that could have been used to save other people's lives already who waited in line for those who didn't need it. And so the policies I would like to see changed would be to accord infectees the same status as vaccinés officially by CDC, which is an example around the world. This would be for so-called immunity passports, jobs, travel, etc. Exempt them from vaccination, except as vaccination requirements that some jobs have put in place. And any prior positive test by PCR, antigen, or antibody would be accepted. Antibody waning doesn't concern me because neutralizing antibodies are not as judged by this assay as proven in the initial Chinese study that focused on total antibody waning, but it was the wrong focus. Neutralizing antibodies predicted to persist for years. And antibodies aren't critical anyway. T cells are the main bulwark of the therapy, of the immunity. This is seen in X-linked A-gamma globulinemia, where patients don't get sick from bad viral infections, they get sick from bacterial infections. Proof that infection is better is quickly available. Look at the Pfizer vaccine study, 20,000 patients per arm, 160 in control arm got infected, 8 in the vaccine arm got infected. If you compare that 20,000 to 20 million patients who've recovered, documented to recover from COVID, that would predict 8,000 second infections, and it's been hard for people to find even a dozen such cases. CDC estimates a 4.6 to 1 ratio of people infected to those who've actually tested positive. And that would mean 138 million people have been infected out of 210 million.
Thank you for your comment. Your time has expired.
Okay, I'd like to say that I'll be posting this material.
Thank you very much.
Thank you.
Our next commenter will be Mr. Del Bigtree. Mr. Bigtree, please state your affiliation and proper pronunciation of your name if I mispronounced it.
My name is Del Bigtree. I am the CEO of the Informed Consent Action Network. I'm the host of the Internet Talk Show, The High Wire. I am formerly a producer of the CBS talk show, The Doctors, where I won an Emmy Award celebrating the best that science and medicine has to offer. I have been attending the meetings at the Advisory Committee on Immunization Practices for over 3 years now, and I've spoken many, many times during public comments, and I have done several now of these over the computer. And I have been saying and trying to make the same point for some time now. You at the CDC and at the Advisory Committee need to start taking much more seriously the visibility of the work that you're doing and the promotion and the PR around it. I have been warning you that you cannot continue to keep promoting products like vaccines made by Johnson & Johnson that have not been properly tested for long-term issues or even short-term issues in the clinical trials. We are talking about a company that has paid out billions of dollars for lying about safety on talcum powder. They always knew it had asbestos. They lied about the OxyContin epidemic, and yet you at the Advisory Committee and at the CDC now find yourself in an incredible situation and something that I've been warning you about. Confidence in this vaccine program, and now the CDC is in grave, grave danger. We now have a vaccine that is just like the AstraZeneca vaccine in Europe, and I am honestly questioning the CDC. Are you going to make the same mistake that the EMA in Europe made and try to cover this up and say, oh, it's going to be just fine, only to have to retract that a couple of weeks later? And now we have nations like Denmark withdrawing the AstraZeneca vaccine because their own science shows that this issue is happening in 1 in 40,000 people. What will be the plan? The CDC, if it wants to hold on to any credibility right now, is, and not risk not only a loss of confidence in our healthcare system, in the CDC, but maybe in science as we know it. I urge you, please withdraw Johnson & Johnson completely. Europe is now overrun. The UK, their hospitals are overrun by people that are panicking even from mild symptoms. Our hospitals can't afford this. This mistake is only going to get worse and worse. We have 2 other vaccine options. Please do the CDC a favor, do this nation a favor, and lead by erring on the side of caution for the citizens and not the pharmaceutical industry, and pull Johnson & Johnson immediately, or we could seriously see the destruction of confidence in all vaccine programs and science as we know it. This is what is now sitting in your hands. Thank you. I hope this time you will finally hear my plea.
Thank you for your comments. Our next commenter is Ms. Marla Dalton. Ms. Dalton, please, your name and affiliation.
Thank you and good afternoon. I am Marla Dalton, Executive Director and CEO of the National Foundation for Infectious Diseases, or NFID. On behalf of NFID, as a long-standing partner of CDC, we appreciate the valuable work of ACIP and the robust U.S. vaccine safety surveillance systems in place. Monitoring the safety of vaccines is an ongoing process, and the decision by FDA and CDC to review reports of a rare blood clotting condition among some recipients of COVID-19 vaccines demonstrates the strong U.S. commitment to vaccine safety. To date, there have been 6 reported cases of blood clotting among the approximately 7 million doses of the Johnson & Johnson COVID-19 vaccine administered in the U.S., clearly demonstrating the sensitivity of the vaccine safety system in place. The fact that public health officials have paused administration of the vaccine to investigate these reports is reassuring to all of us who are committed to vaccine safety. And we at NFID stand ready to help communicate the results of the data analysis and any implications for public policy. The actions taken by CDC and FDA also illustrate some of the core principles of communicating about COVID-19, which are outlined in a new NFID report, COVID-19 Communications, Promoting Prevention Measures and Vaccine Confidence. The report, which was developed with input from more than 50 leading organizations and multidisciplinary experts, is now available on the NFID website at nfid.org. As the science and knowledge around COVID-19 continues to evolve, being open and transparent about what we know and what we do not yet know helps all to manage expectations and reduce anxiety and confusion about vaccines and other COVID-19 prevention measures. The work of ACIP in guiding U.S. immunization policy and overseeing vaccine safety is vital to protecting public health. On behalf of NFID, thank you all for your dedicated service.
Thank you for your comments. That ends our public comment session for this meeting. Dr. Cohen, do we want to proceed or give the group another 5-minute break?
I think if you're okay with that, I think we can go ahead and proceed.
Very good.
We can both continue to ask questions and then also maybe bring up the last slide that Dr. Oliver shared so we can remind the committee what the questions that we're posing to ACIP to discuss are. Thanks.
Correct. Let me also return to Dr. Sanchez and Dr. Goldman, who have been waiting patiently to ask their questions. Dr. Sanchez, please go ahead and ask your question.
Thank you, Jose. It's more of a comment. I think, first of all, we do have a positive message that we do have 2 vaccines currently available in the United States that have not been associated with these thrombotic episodes and clotting disorders. So I think we need to have a positive message there, beyond the fact that the VAERS and other reporting guidelines have seen the signal. But my other question also is, are these cases being investigated further in terms of autopsy? And I guess I could have asked that earlier, because is there something unique about, not having, with the messenger RNA ones, not seeing this? Is it something about the adenovirus vector? And is there anything in these, are autopsies being performed? Are these thrombi being examined? Are they finding the adenovirus vector within them? And maybe I'm being a little bit too simplistic. And certainly, what is the inflammatory, signal there? Is there something within these clots that are different than other cases? And I just wonder if I just urge for more investigation, more autopsy specimens, and more and looking at these thrombi and seeing if we can see something in there that may have been triggered by the actual, whether it's the adenovirus vector or something else in the vaccine. Thank you.
Thank you. Dr. Goldman, please.
Thank you, sir. More of a comment as well. Certainly as a practicing internist, I'm really reassured that the VAERS system works. And I really want to reiterate what has been stated before, how important it is for my colleagues on the front lines to be utilizing it. And I really want to thank the CDC and ACIP for the on, as these clinical guidelines really do help us treat the patients on the front line. Now, in regards to the policy question, certainly short-term and long-term, as a practicing internist, for the immediate future, I'm definitely in favor of a pause as we see if more cases come out, because the true incidence of this condition may be revealed now that we've had so many more doses administered. And certainly now that my colleagues are aware of this issue, I suspect more will be reported as it is recognized. But I would also suggest we consider the risk versus benefit of the vaccine compared to the risk of getting COVID itself and the potential of death from the disease. And we may lend ourselves more towards an individual decision on which vaccine the individual may want to choose to get, although this could be complicated logistically. And in the long term, I really am hopeful we can see if this is an issue with the vaccine adenovirus platform, or is it an issue with this vaccine specifically. Regardless, I really want to stress to the public that they need to remain confident in our process and the science regarding vaccines in general, and that we need to continue to vaccinate against COVID and so many other diseases, and not to let this sour their decision on getting vaccinated in general, because I really do believe the VAERS systems work, and we do have confidence in the process, and that we'll make the right decision regarding public safety. Thank you.
Thank you very much, Dr. Goldman. And I just want to make one more comment regarding the data that was presented by Dr. Oliver. As usual, an excellent presentation, but the data on race and ethnicity is notably weak, in my interpretation. I don't know where we are on the exact number today, but as of 3 or 4 weeks ago, only 50% of those individuals receiving the vaccine had provided information regarding race and ethnicity. So I caution you on making any extrapolations based on the data that we have at this time. And so with that, we're going to proceed to this discussion. And Dr. Oliver, would you please start us on this issue and put up the questions that we are to consider, and then we'll open it up for a discussion.
Yes, thanks. So the questions that we brought before ACIP today is, does ACIP have enough information to make interim age or risk factor-based recommendations for use of the Janssen vaccine? And then what recommendation does ACIP feel is appropriate today, given the currently available information for use of the Janssen vaccine?
Thank you very much. So as we begin, let me point out to the voting members of the committee, that we do not have to arrive at a vote today or a recommendation today. If we need more information, if we need more time to think about this, we can reconvene later this week or this weekend if necessary. This should be a considered vote based on the data that you all need. Having said that, I'd like to direct some words to the general public that are watching us and listening to these presentations. It's been stated multiple times throughout this meeting that safety has been a paramount issue in our deliberations for this vaccine, for recommendations, and for following the vaccine. As we started our deliberations in April of last year, that was foremost on the list of things that we needed to keep in mind, and we are doing that at this time. The FDA has stated the same, and pharmaceutical companies have stated also that safety is the ultimate goal here in the vaccine. Our systems for identifying these rare adverse events work, as pointed out by Dr. Shimabukuro and others. The fact that we have identified these very rare clotting incidents points to the robust safety systems that are in place and make our vaccine safety systems some of the strongest in the world. And I think it's important for the public to understand that as we go forward with new vaccines, we continue to have ongoing safety checks. With regard to the issue of vaccines and in general in the public, I think we all know that we are encountering vaccine hesitancy or reluctance regarding the use of these vaccines for the prevention of disease. Dr. Goldman spoke to this, I think, just now, and we need to have a decision and come to a decision regarding recommendations in a timely manner, and ask if we do pause, that the pause be sufficient to address the question. This is an issue of safety and risk-benefit analysis. We may not answer all the questions at this time, but we need to come to a decision on this in an appropriate time frame and not delay it. This reminds me of the talk that Dr. Frieden gave us when we were discussing a pneumococcal vaccine. And we have the data before us. We need to act on that data as appropriate and add to that data as we go forward to modify or to strengthen it. So I'll turn it over to discussion at this time. Let's begin. I believe Dr. Fry has her hand up first. Please.
Thank you. This is Sharon. I'm just curious what the working group had discussed regarding just clotting in general and DVTs or PEs or what have you in general, and whether that was taken into consideration. I know that we're talking about CVST here with thrombocytopenia, and that's very unique, but is there an increased incidence also in clotting without thrombocytopenia? And did the working group talk about this at all, or there clearly is not an increase, or how is that factoring in the overall picture? Maybe Beth, you might.
Sorry, Sharon, are you talking about other clotting events with thrombocytopenia?
Without.
Or are you talking about clotting events in general with or without thrombocytopenia?
The latter, with and without thrombocytopenia. Was there an increased incidence of that in general also?
We did not focus on that.
Okay, thank you.
Thank you. Dr. Long.
I would just echo what Sharon said. You know, the thrombocytopenia, which is so telling here, it may be, only very severe, and it may be only severe that really gets your cerebral sinuses. So the others are much harder to figure out because the underlying occurrence is so much higher. But I would think we are ready to make an interim decision to continue a pause for at least a month until we see what else comes out about does it occur in men. We now, in the most recent weeks, are immunizing younger and younger individuals. And we might be able to make some risk-related, more definitive potential use of the vaccine again in a month. But I suspect, because of what we know now, that this occurrence of these events has been in half the number that we have as the number immunized, considering when they could have occurred and could have been reported, and that we're going to get many more things occur in the next month that will help us with a more definitive. So I would be very much in favor of a continued pause, and I think I would be opposed to continued use at this time.
Thank you, Dr. Long. Dr. Bernstein.
Thank you. I wanted to make sure that I understood Dr. Fink's statements representing the FDA. Did I understand a risk management approach, and which included warning statements? And I was wondering what was meant by warning statements and how that actually would be operationalized in the real world.
Thank you for that question. The warning statements that I mentioned would be warnings in the EUA fact sheets for healthcare providers and recipients that are given to vaccine recipients at the time or before actually the vaccine is administered. And the risk management approach would be warning statements in combination with other communication from FDA, CDC, and other sources.
Thank you. Yeah, the EUA fact sheet is multiple pages as it is. And many of the people receiving vaccines are not having an opportunity to talk with their own provider about it. So there might be a disconnect in some way.
Thank you, Dr. Bernstein. Ms. Bata.
Sorry, trying to find my unmute. As I've been hearing this data and understanding how rare this event is, and what I've heard in conversations over the last 24 hours, there's two sides of this. There's you're overreacting, and then the other side is you should just stop this. And I know that there's been consideration of a provider risk-based discussion about continuing to use the Janssen vaccine for those who would feel comfortable. But I think that I'm coming on the side similar to what Dr. Long and Dr. Fry have said, that it would be helpful to have some additional information. And by having a little more robust information, I think we can be much more confident in how we talk about the safety of this vaccine. Because right now, the confidence for COVID vaccines is just right at a precipice. We've got people that can't wait to get it, and others who have been waiting and seeing. And this will, I think, contributes to that confidence that people have. And so I would be in favor of getting more information.
Thank you, Dr. Alt.
Well, my question or comment is kind of a corollary to that. How did the working group discuss how much longer they would need to get this information? I mean, we do have a meeting scheduled May 5th, which is 3 weeks from now, not a month from now. And I was curious to know, what the logistics were there.
This is Dr. Bell. I would say that there sort of wasn't a final conclusion about how long would be necessary. I think there was a general sense that there needs to be enough time to provide the kind of data that the working group felt was necessary, but also that it was extremely important to do this as expeditiously as possible because of all of the potential unintended consequences of a prolonged pause.
Thank you. Dr. Talbot.
Yes, so I probably will reiterate some of what other people have said, and pardon me for doing that. But I want to say up front, we are very fortunate because we have multiple other alternatives in the U.S. to help stop this pandemic. And we have very good, well-proven alternatives that we are not seeing safety signals in. So I think that puts us in a little bit of a different position, and we can be much more cautious and thoughtful and use the old motto of first do no harm. And so I think truly in a setting where we don't have enough data for other thrombotic events such as stroke and DVT and PE, we should have the time to do that. I also think we're in a setting where the usual treatment may be rather harmful, and so we can't say, oh, this is treatable, let it go. Thirdly, I think we don't know enough about age yet. My suspicion is that events like strokes may be underreported or not flagged, and these occur more often in older adults. So I'm very hesitant to say it does not occur in anyone over 50. So I feel like we're fortunate and have the opportunity to wait a period of time and continue to hold until we have this information, and strongly encourage people to continue using our messenger RNA vaccines that have proven to be safe and effective until we know more. And if we can say the Johnson & Johnson vaccine is incredibly safe and we're not worried about this, we will come back and say that. If not, then we've done no harm and we've been able to continue vaccinating in the meantime. Thank you.
Thank you, Dr. Talbot. Dr. Sanchez.
Thank you. I agree with Dr. Long and the others. I think that a continued pause is what I would favor and recommend. At the current time, I am not continuing vaccination of any individual with this product.
Sanchez, thank you. Dr. Bell.
Thank you very much, Dr. Romero. I thought I would just give my own view on this topic so that, I have an opportunity to comment. Basically, to be very frank, I do not want to vote on this issue today. I do not want to vote not to recommend the vaccine. I think that is not really something I necessarily believe. But I do not feel that we have, it's not surprising. We've, been kind of looking at this issue for 2 days or less. I just don't feel that we have enough information to make an evidence-based decision. We won't have all the information, but I think there are some things that we can gather relatively quickly, which all have to do with the benefit-risk balance. We do need to better understand the risk, which we know is going to be very rare, very low, but we really don't know exactly how low and how to correctly characterize it, what the denominator should be, what is the numerator, how many cases are there with thrombocytopenia that is not CVST, as an example. So there's a number of things like that. Second, we need to understand that risk, whatever it is, in some kind of context. With other things that might cause thrombosis, for example, because I think that it's important for the public to understand when we say rare, what does that mean with respect to other risks that we might take every day. And then thirdly, I think we need to, have some sort of formal risk-benefit analysis that allows us to very clearly point out to the American people why we think it is the risk-benefit favors whatever the recommendation is that we end up with. I mean, I want to be able to, feel comfortable with my family members, myself for that matter, to receive this vaccine. Nothing is risk-free, and as people have said, we are ahead of ourselves here because we so quickly identified this and because of what's been going on in Europe. So the bottom line of this long exposition is I do not think we should vote today. I think that the implications of a vote not to recommend are stronger than I at least I do not want to send that message. So I think we need to not vote and gather the necessary information so that we can make an evidence-based decision.
Thank you, Dr. Bell. Sorry, was that Dr. Cohen?
Yes, I just wanted to add and clarify that we do have a scheduled meeting on May 5th, but if we need to have, if the ACIP, if we can pull together information and we can come back before that period, we don't have to wait until May 5th to have a follow-up discussion.
Thank you, Dr. Cohen. So, sorry, Dr. McDowell, let me just say this, and then sorry, Ms. McDowell, I'll turn it over to you. Yes. So that was, certainly one option that we could consider is that to continue this pause until our next meeting, or we could meet sooner if there is more information that allows us to make a final vote, a more concrete vote prior to that time. I think, as Dr. Alt pointed out, and now Dr. Cohen, that we have another meeting in 3 weeks. And that would fall in this period of a pause and allow us to get more information and see what more cases come forward. Ms. McNally, please.
Thank you. And I think I may have a clarification question of Dr. Shimabukuro. So it seems to me that it's very reasonable to try and gather more data. And if I understand it correctly, from the cases that Janssen talked about that were reported directly to Janssen, ultimately those cases were reported to VAERS. And I'm just wondering if Dr. Shimabukuro can comment on what might be a reasonable period of time for us to gather more data and reevaluate. Thank you.
Well, if you look at I have to pull up my own presentation here. I think the median onset was 8 days, 6 to 13 days. So you've got individuals who have been vaccinated who I think we want to follow out for what we think is maybe a reasonable risk window and time to actually capture any cases that might be identified in that, capture and evaluate any cases that might be identified in that risk window, which looks like about 1 to 2 weeks. plus, I mean, there may be cases out there which have not come to our attention, but might come to our attention now that this information is out there. We call that's a reporting bias called stimulated reporting. So I do think in the coming weeks we are going to gather more information. We're going to continue to gather more information, we will continue to get better, more specific information as we can access the medical records, where we'll get a better picture of what's going on. We are going to refine our observed versus expected analysis. I know that the folks at the FDA are working on that. So I think in the coming weeks, we will have more information and better information where we can assess the signal and possibly characterize the risk.
Thank you.
Thank you.
Dr. Fry.
Thank you. I was just wondering, a question for Dr. Shimabukuro. What is the delay in entering data into VAERS? So if someone has an adverse event, such as a CVST, how long does it take for the physician to actually report that data after the event? Thank you. On average.
Well, I mean, the decision to report, report really happens at the healthcare provider level. We encourage that there are reporting requirements under EUA, and this would constitute a serious adverse event because these individuals, at least for the 6 that we've observed, are hospitalized. So this would fall under the emergency use authorization reporting requirements. CDC's recommendation is to report an adverse event as soon as possible after the onset of symptoms, or after a person or a healthcare provider becomes aware of the symptoms. So we want to get these reported to VAERS as quickly as possible. And that's one part of it. The other part is how quickly do we process, follow up, and analyze these reports. And I mean, because we were following these reports, these types of reports closely because of what was happening in Europe, we are basically reviewing these in collaboration with FDA is in fairly close to real time. They come in, the categorization of serious or non-serious is made known to us quickly. We can review these serious reports. We can identify potential CVST or other thrombotic events. And we can expedite records collection, where either we direct the contractor to expedite collection on a specific report, or we just simply do it ourselves. So we have ways of compressing that timeline, and our focus now is to make sure that we identify and follow up and assess and analyze these reports as quickly as possible. So I think on our end, it's a fairly quick process, and based on the reports that we've seen that have come in, providers are reporting those in a timely manner as well.
Thank you. Dr. Lee.
Thank you. Sorry, you're going to have to bear with me. I've been thinking about this for 48 hours, and so I wanted to just make a few statements and put out a few requests. Everyone acknowledges that risk is an inherent part of life. We would not be vaccinating anyone if there weren't a COVID-19 pandemic ongoing right now, that there is a population level benefit risk balance that we need to consider, and individual benefit risk balance. I think the role of ACIP in this instance is to focus on mitigating that risk. We also need to better understand the benefits, because I've also seen patients, and I know many of you have, admitted with clotting disorders and thrombocytopenia, sometimes immune-mediated thrombocytopenia associated with COVID-19 disease. So we really need to have a balanced picture of both the benefits and the risks. From the ACIP perspective, I think there are 3 things we can do to mitigate risk. One is to identify populations at the highest risk for this potential complication and adapt our recommendations to minimize exposure to those at highest risk for this potential adverse event. The second is to educate patients about the benefits and risks of different vaccines and to ensure that patients seek care in a timely manner. And the third is ensuring that our healthcare systems are able to diagnose and manage these cases in an incredibly timely way. Because if we can manage these cases early and well, similar to anaphylaxis, we may be able to employ strategies that change the outcomes that we see with these patients. So that said, I also just have to comment that, this is so challenging because the impact of ACIP decisions on the global stage is clear to me, given our past experience with rotavirus vaccines. And I think that the benefit-risk balance may be very different in other countries where vaccines are either not available or not feasible for widespread implementation. And I recognize that our responsibility at ACIP is to individuals in the US, but I also feel the weight of the burden of a global responsibility that we also have and the impact that our decision-making could potentially worsen inequities. So regardless of whatever decision we make on this particular safety signal, I think it's important for us to make sure that we're collaborating with partners outside the US to address those inequities in whatever ways we can. So then thinking about what we need to do ahead, what information is needed before I think a vote can be taken. I agree with Dr. Bell. I don't think we have enough information today. I think we need to go through the signal refinement phase where we can capture age and gender stratified rates of CVST and the outcomes associated with CVST among both vaccinees and those with COVID-19 disease. That we have a better understanding of risk factors associated with CVST and those who have poor outcomes associated with CVST. We need to review the data across multiple vaccine safety surveillance systems, and I wholeheartedly agree that we need a formal benefit risk assessment to make a well-informed decision. We also need to move through the signal refinement phase, I think, as quickly as possible in order to be able to support evidence-based decision-making. So, and I know everyone knows this around the table, but we really need strong collaboration across the federal agencies and with global partners in order to be able to make the best possible decision in as timely a manner as possible, because I continue to feel we're in a race against time and the variants, but we need to do so in the safest possible way. Thank you.
Thank you very much. Dr. Cotton.
Thank you. Grace, I very much agree with what you said. I would just like to add that the putting this vaccine on pause for those of us that are frontline healthcare workers has really been devastating. I agree in general that we don't have enough time, we don't have enough data to make a decision at this time, but we were planning on using this vaccine in the state of Massachusetts for people who are homebound and otherwise not able to get a vaccine. We were planning on using it for our vulnerable inpatient population, often with many comorbidities and at high risk for disease, but who haven't been able to get vaccinated otherwise. And then it certainly was going to be used in what may be otherwise underserved populations or populations that aren't able to get mRNA vaccines. So I definitely want us to be cautious and very careful with our decision making, but I also just want to emphasize that this one and done vaccine that didn't require the cold chain that the mRNA vaccines do is, it's a significant loss. And I just wanted to highlight that for sort of the underserved populations that did need access to this vaccine. Thank you.
Very good. Any other comments from the voting members? Dr. Cohen, we have a hand up from one of the liaisons. Are they allowed to comment at this point?
Yes, that would be great. We can move to some broader comment. Before we do, I just want to summarize a couple of the things that I've heard and give some potential options moving forward. So it sounds like we have certainly heard that there's a need for more of a refinement of the risk as well as risk-benefit analyses. And I just want to remind everyone that the goal today was to be as transparent and communicate information as rapidly as we had it available with the ACIP members, with our liaison organizations, and with the public, knowing that some of this work we will be doing around the clock over the next several days. So we are working on those analyses. I think one of the questions for ACIP today is, with what we've been presented and not having that additional information, is ACIP comfortable preferring to continue the current pause or not make any decision about this at this time? Or is there any, or do people prefer to refine or to make a recommendation around shifting the pause for a short basis, potentially, for example, pausing just in a certain population versus the entire population that is currently paused at this time? So when the word interim is made, that interim shift can be for just a week or two as we try to refine. I know typically when we make interim recommendations, we're thinking for longer periods of time, but there are lots of different options here, including just just waiting for more information. But I do think that there's a critical question about if the pause should continue for the whole population, as some have indicated, versus should that potentially be refined?
Thank you. Let me turn to other comments now. Dr. Shah?
Thank you, Dr. Romero. Good afternoon again, everyone. This is Neerav Shah. I'm speaking in my capacity as president of the Association of State Territorial Health Officers. I'm also the director of the State of Maine Center for Disease Control. And I must express concern about the direction that I fear the committee may be going. We are in a situation where not making a decision is tantamount to making a decision. Any extension of the pause will invariably result in the fact that the most vulnerable individuals in the United States, who are prime candidates for the Johnson & Johnson vaccine, will remain vulnerable. The most at risk will remain at risk, and those who would benefit immediately from vaccination will remain unvaccinated for an unknown period of time. That would come at a period where the United States is still logging 5,000 deaths in the past 7 days just across the country, and at a time when there were 489,000 new cases just in the past 7 days. The initial reason for the pause was, among others, to ensure that healthcare providers and recipients were apprised of the possible risks, as well as to be on the lookout for them so appropriate treatment could be given. It's always possible to get more data, and indeed, in the history of pharmaceuticals, we are always refining our understanding of risk. That's always part of it, but there are also tools available today to better evaluate and mitigate that risk while continuing the provision of the J&J vaccine. I would urge that any pause be counterbalanced by consideration of the equity considerations that would befall from any lengthening of the pause.
Thank you very much. Dr. Freihofer.
Sandra Freihofer, liaison for the American Medical Association, speaking as an individual, as a practicing physician. I must tell you that this whole process today has really increased my confidence in vaccine safety. I greatly appreciate the honesty and transparency and the quick action that the FDA and the CDC have taken. I have listened to the comments from our esteemed group of ACIP members, and I hope that when the membership does vote, that they will, that I personally hope that they will support some pause so we can figure out if this is a needle in the haystack or the tip of an iceberg. There are other vaccines available. There is a supply of these vaccines. And I am so sensitive to the equity of vaccine distribution. I know that there are many patients that have not been able to get vaccinated, that need to get vaccinated, but we want to make sure these vaccines are safe. And I do think a short pause to give us a chance to collect this information, to give physicians and patients time to, to understand what we've been talking about, and there might be more cases coming out. But at the end of the day, I just really respect the process, and I'm proud to be a part of it.
Thank you very much, Dr. Freihofer. Dr. Talbot.
Yeah, I just wanted to say briefly that I do appreciate the comments about getting to those who are homebound and are difficult to find. I do, however, want to say that I am also worried that those that cannot get to the medical care and those who are difficult to find may be at risk for severe clot if they do develop clot and may not get to care in enough time. So it is a double-edged sword, and it is concerning. And I think that's why many of us would like the risk-benefit analysis so that we can help figure that out. Thank you.
Thank you. Dr. Dushin.
Thank you. Jeff Duchin, Infectious Diseases Society of America. I would just like to reemphasize for the public that what we're talking about is a very rare, albeit serious, event that's associated with a vaccine that was detected through our vaccine safety system. And that if the ACIP elects to pause further, it should not be interpreted as a signal that there is an increased concern about vaccine safety today beyond which was evident initially, but a desire to better characterize the risk in order to make the best possible guidance going forward. Thank you.
Thank you very much. Are there any other comments from the liaisons or the working group members? I'm not seeing any new hands. I'm not seeing any. Dr. Long, please.
We didn't really answer the question for Dr. Cohn about could we parcel out any less at risk, more at risk groups in rather than just an universal pause. And I think we would be uncomfortable with that because, the lack of specific and large data that would help us decide this person is less at risk, more at risk. Certainly everybody is at risk, and although it's a very small risk, it is so serious. I mean, this could be limb, life. It could be a severe consequences for your life, neurologic consequences. So I think that there would be, although I understand the unintended consequences, I think we can live with the unintended consequences because the amount of vaccine that we do have, and it would be the wrong message and a real mistake to the people who would be getting this. We're not able to inform them accurately at this moment about the benefit, the risk. So I think that we can't parcel out groups that are more or less at risk because we don't have enough information. And I would speak again in favor of a pause until we have better data.
Thank you for those comments. Let's see, is Dr. Lee?
Yeah, I just, reflecting on Dr. Long's comments, I do think that, obviously all of us care very much about safety and individual and population benefit risk balance. I'm struggling with the idea that I don't think an indefinite pause is a good thing. I just think we're going to have whatever data we have and make a decision. I think the main question I have is whether or not we think we can assess where we are in another week or two. Even in the last 48 hours, a tremendous amount of data has come out. and work with our colleagues to come up with a sort of a time frame for this. But I think an indefinite pause is, as Dr. Shaw mentioned, functionally a decision, and I would not advocate that because that is not the decision I think that makes the most sense.
Dr. Lee.
Dr. Bell. Sorry.
I was just going to respond to Dr. Lee. I completely agree that we definitely don't want it to feel like an indefinite pause. And I think just if ACIP, from a process perspective, if there is no motion or desire to vote on a recommendation today, that would result in us going back to work as quickly as possible and coming back with an additional emergency meeting in a week, 10 days, 2 weeks at the most. But we will try to get the work done that we need to get done to present to you as quickly as possible. And we would, try to provide enough information for a decision at that time.
Thank you very much, Dr. Cohen, for providing that time frame. You anticipated my question. Dr. Bell.
Yeah, actually anticipated my question as well. I do not want to be sending a message that we are more concerned, that there's a message that there's some huge concern here of a different order of magnitude than any other vaccine safety signals that we evaluate, because that's not the message that I want to send, and I don't want to send a message that there's something fundamentally wrong with this vaccine, because that also I don't agree with. So whatever the process is that allows us to, as expeditiously and quickly as possible, have enough information, which is never all the information, but it is hopefully a few of the kinds of things that a number of people have mentioned that are important and are necessary, as quickly as possible. However we do that, however we can do that, and Dr. Cohen, sounds like you've just explained it, that's what I would like to do, because, as I say, it's a very rare event. Nothing in life is risk-free, but I want to be able to understand and defend the decision that I've made based on a reasonable amount of data.
Thank you. I don't want to cut this discussion short, but I just want to make sure. Dr. Cohen, is there a time frame in which you must end this meeting because you have to leave that building where you're in, or can we continue as questions keep coming up or comments come up?
We are fine continuing the questions. I think that if we could shoot for 5:30, that would be great. But I don't want to cut the conversation short.
Perfect. Thank you. Neither did I. So let me see here. Dr. Alt, is your hand up?
Yes, I just wanted to go back to Dr. Bell, because really the point of my question that I asked earlier was I don't want an indefinite pause either. That's why I was curious about what kind of time frame we were talking about. So I'm reassured hearing that this could be a relatively short amount of time.
Thank you. Dr. Bernstein.
Yes, I agree. I would not want this to be an indefinite pause. Maybe Dr. Oliver can answer this. I was interested to know how many J&J vaccinees can we expect data from, in what time frame, looking forward over the next week, 2, 3?
Can anyone hear me?
Yes.
Yep. Okay. Dr. Oliver, did you have an answer for that?
Okay. Can you hear me now?
Yes, we can.
Okay, perfect. I think I had a mic issue earlier. So the 3.8 million doses were administered in the last 2 weeks. I don't have a further breakdown on each week. As Dr. Shimabukuro mentioned, we expect some stimulated reporting now that all of this is out, and that we're highlighting and kind of asking for reported cases. So we would expect that the delay between presentation and diagnosis and then diagnosis to reporting to VAERS would actually be, a much faster kind of turnaround now that the HAN and other, educational methods are out. So we'll have to see, but I think we anticipate, that we could get additional information on cases. If they're out there, we will find out about them hopefully relatively quickly.
Thank you. I see Dr. Dushan's hand is up. Did you want to ask another or make another comment, Dr. Dushan?
Sorry, taking it down.
No, just making sure.
Thank you.
And Dr. Alt, yours is still up, so I just want to make sure. Dr. Shah?
I must express concern again over this line of concern or discussion. My concern is as follows. I understand the rationale behind the pause, but we should also have a theory of lifting the pause. And if the concept of operations right now is to simply accrue more data without a theory of what those data may mean and how we might evaluate them, it is just as possible that the committee may in 3 weeks say, well, let's just hold on for even more data. So if we are going to have an extension of the pause, we should at least couple it with the theory of what lifting the pause may look like and under what criteria we would do so.
Thank you, Dr. Shaw. Dr. Lee.
Thank you. I'm hoping I can respond to this, at least with my own opinion. To me, it's not data in terms of having perfect data, because we'll never have perfect data and there will always be uncertainty. But it's really, for me, about getting better risk estimates and understanding the action recommendations, if we can, to minimize exposure to those who may be at highest risk for this particular adverse event. It's possible we may not have any more information, in which case I still think we're going to have to make a decision or a recommendation at that time. But I think that my hope is that in the next week or two, we can actually capture that in a more robust way, because I feel like the benefit risk balance to me is unclear without having the risk estimate of this particular potential adverse event by age, by gender, and understanding other risk factors that may contribute. So that's my hope, but I agree we need to make a recommendation soon.
Thank you. Are there any other comments? I see no hands at this time. So am I summarizing it correctly that we are not ready to vote at this time?
Dr. Romero, what I'm hearing from the ACIP members and liaisons is that there is a strong desire to reconvene as quickly as possible after both some risk benefit as well as additional risk refinement has been done, which we will do, which we will commit to at CDC is doing as rapidly as possible. And at this time, ACIP would not provide any, does not wish to vote or put any motions on the table to vote for a change in the current recommendation. So while the recommendation is paused, we would still have our current recommendation. And we would continue to pause on that until, CDC would likely choose to pause on that. I can't confirm, but this would be providing no recommendation to our director until we meet again in a week or 10 days.
Excellent. Very, very good. Does anyone on the committee have a opposition to that? Okay, I guess seeing no hands, very good. That's as you said, Dr. Cohen. We will go forward.
Great. Then I think the meeting can be dismissed, and we will find a time to reconvene. We anticipate today is Wednesday. We'll try to identify what that date is by Friday of this week so that people have a little bit more time to get it on the calendars. And we will, and we, appreciate all of your time and all of your guidance and expertise that you've provided us today, even though we did not make an official recommendation. Your input today was incredibly helpful in terms of helping inform our work over the next week.
Thank you. So with that, meeting adjourned, and we will wait to hear when we will reconvene. Thank you very much.